morning, ladies and gentlemen, and all the colleagues either from Hong Kong and Taiwan. I'm Wang Mingfang from Mekong Changde Memorial Hospital, and it's a great honor to have a brief talk with you about this topic, which is the workflow, working environment, and scope of work, Hong Kong versus Taiwan. This is my outline as the topic. I will first talking about the working environment and emergency department population. And next, I'll talk about the workflow of our daily shift. And at the end, I will talk about the current emergency department demography. First, let's talk about the emergency department population. In 2016, there are over 23 million of people living in Taiwan. And during the same year, according to the government, that the statistics show that there are over 12 million of visits in the emergency part. And that equals one of the two people had at least go to the emergency department during that year. And next, I'll talk about the triage proportion. Taiwan's hospital can roughly categorize into the medical center, regional hospital, and district hospital. And we can show that in the medical center, the critical and emergency group have totally accounts for 23% of all the visits. That's quite different from the regional hospital and district hospital. In regional hospital and district hospital, it accounts only 16% of all the visits and 8% in the district hospital. And there are two main reasons that will cause this difference. One is the ambulance and the EMT will transfer the patient to the suitable hospital initially if patients are in critical status. And number two reason is that if the critical status is in the regional hospital, they will transfer to the medical center through the emergency department, and that will cause a big difference. And next, this is the analysis of our emergency department visits. You can show that the number one ranking that shows only with diagnosis with the symptom and syndrome without any very serious disease. And for example, only for sore throat, like abdominal pain, myofascial pain, shoulder pain, something like this. And number third most are the respiratory syndrome, including the influenza, asthma, or any bronchitis. And these two very easy disease cost 1/3 of our total visits. And next, I want to talk about the time proportion. In some of our medical center, we have divided patient into the medical group and the trauma group. And the trauma group will be treated and evaluated by the trauma surgeon. And back in this graphic, we can show that either the medical group and trauma group show the same proportion, almost the same proportion according to the time period. And there are almost 20% of people will visit the emergency department in the night shift. And next, I want to talk about the waiting time, which is quite different for Hong Kong and Taiwan. We can show that it is the data in 2012, that it is without doubt that the patient in the critical group and the emergency group will be first evaluated within 10 minutes. However, in the urgent group and semi-urgent group and also the non-urgent group, the patient in Taiwan will be first evaluated within 15 minutes. And let's look at the recent data in our own hospital in last year. We can show that almost all patients will be evaluated within 15 minutes. But however, under these circumstances, the patient in Taiwan will still argue about why they wait so long for the doctors. I think they're very irritable and mania. And there's another big difference is that after we have the first assessment and we think the patient needs to be admitted, we still have to make the diagnosis. So, for example, if the patient comes with fever and right upper quarter abdominal pain, we have to do the lab draw and arrange the CT scan of abdomen. And after we made the diagnosis of acute cholecystitis, we just consult the surgeon and we can arrange the ERCP in patient with high risk of operation, or patient that is suitable for the operation, we can just arrange the pre-OP survey for them and send to the operation room through the ER. And let's take another example. If the patient just comes with ischemia stroke within 3 hours, we can do the TPA injection. Or patient with the altered mental status, We can do the MRI of the brain, and also we can do the lumbar puncture if we think that he might have a CNS infection. And not mention of other procedural examination, such as the penendoscope or either the hemodialysis. And next, I'm going to talk about the authority of admission. There are two kinds of authority of admission. One is the emergency department had the authority. Then we can just admit the patient to the specialty that we think that is suitable for them. And the second kind is that the internal medicine had the authority. Then, if we think the patient needs to be admitted, we have to make a phone call to consult them. And they will come to the ER to pick up the patient who they think is suitable for their specialties. Then this comes out with the problem, because people in Taiwan has a lot of comorbidity. If a patient same time has the cirrhosis, hypertension, diabetes, or end stage of renal disease, then no department wants this patient to be admitted to their department. And this will cause a longer stay at ER and problems in emergency room. Next, let's talk about the length of the stay. After we admitted the patient, we will transfer them to the observation room. And this is the admission less than 6 hours of proportion. You can see that only in the regional hospital and the district hospital has better less than 6 hours of admission proportion. It is over 90%. However, in the medical center, the bed availability is not that good. So only over 60% of patients had less than 6 hours of stay in the ER. The next graphic shows that it is the length of stay more than 24 hours of proportion. You can see that in the medical center, it is over 8% of people in a patient in the critical group, and over 7% in the emergency group that will have longer stay at emergency room. And this is the recent data from our hospital. You can see that in average, almost all patients need to be stay at the emergency department for about a day. And next, because this long length of stay at the emergency department, how about our working load? This is how many patients does one resident have to cure in one shift. This is the recent data of these 5 months. We can see that at least the resident had to see 1,686 patients, and the most you can see up to 3,001, and that is in 5 months. And every month we have 16 shifts, so that equals 80. So in every duties, our duty is 12 hours for the resident, that you have to see at least 21 patients and up to 37.5 patients in one shift. And last, I want to talk about current ED staff demography. Till now, there is 1,631 physicians now working as an emergency department specialist. And 91% of them are male, only 9% are females. And over 86% of them working in the hospital. And the others are working in a clinic or any government institute. And this one shows the emergency department are steadily growing specialties. Whether enter the emergency department or leaving the emergency department, or enter the hospital or leaving the hospital, are only in small amounts, and they are keeping balance. And most of them, over 97% of them, are just staying their career as an emergency physician working in the hospital. So, in conclusion, the emergency department in Taiwan is combined with convenience, quickness, and crowded. And we have rich resources to help the patient in the emergency department. However, the crowded of the ward build up the crowded of the emergency room. So we have longer lengths of stay at the emergency room. And it will cause not only have to realize the acute phase and subacute phase of certain diseases. And emergency department is a relatively new specialties in Taiwan, and hope one day in the future we can help our patients in our own nation. I'm Yi Fan Wang from Liko Chang'an Memorial Hospital. Thanks for listening.